it is 12:30. We'll start right on time. Welcome everyone to Project Echo Geriatrics. I'm so glad you can join us today for this August Friday. I hope you all have been able to enjoy some of the summer. We are going to run the session like we normally do. We'll start off with a short didactic focused on a primary care topic relevant to older adults. And we have a really wonderful speaker who will be familiar to many of you. And then we'll go into a case discussion. And Dr. Slack submitted a complex scenario for us to talk through, and we'll do that all together with all of you and with our interprofessional expert team. So I'm excited to get started. Carol Crawford is a clinical pharmacist, and I get the pleasure of working with her every week in senior care clinic. She has deep expertise in geriatric pharmacy, and she is wonderful with patients, very patient-centered and age-friendly in her approach, and I'm always learning something from her. So I'm really glad that you're going to talk to us today. She's going to be talking to us about the GLP-1 medications that are all the rage, but we don't know as much about how they impact older adults, and Carol knows more than all of us do, and she's going to share that with us and answer some of our questions. So Carol, thank you so much for taking the time to talk to us today.
My pleasure. My pleasure. Okay, so let me just hopefully queued up here, and I'm assuming everyone can see my screen.
I can.
Yes.
That looks great.
Okay, perfect. Yeah, so I am going to be speaking about the GLP-1 receptor agonist and their usage in the elderly. And I'm going to call them just the GLP-1s because it's a lot to kind of say each time. So hopefully that's acceptable. And I'm not going to talk or drill down too much on the pharmacology or mechanisms of action of these medicines, except for one slide, just because I want to make sure that, or hopefully make sure that everyone here, since we're this multidisciplinary team, has some takeaways and some applicability to their particular discipline. So I'm going to start with a case, and then I will speak about the available GLP-1 receptor agonists and their indications. We'll talk about why so popular these agents are, and then speak specifically about the elderly and offer some cautions and recommendations. So this case was actually a case that was presented at the 2024 AGS annual conference. And I'm using it again because I do find that it is a really good example of how things can get complicated when we're using GLP-1s, and how some of the things that we need to be kind of alerted to. So this patient was an 86-year-old female patient living in an adult family home, past medical history significant for dementia, type 2 diabetes, and obesity as defined as having a BMI of 30. She had poor functional baseline, needing help with her greater than 2 of her activities of daily living and requiring 24-hour supervision. And importantly, her diabetes actually historically was well controlled on oral agents. She did, however, have a back flare, is what is reported, and started on some oral as well as injectable steroids, and are increased, and so she had an increase in her blood sugars to 250-300 range. She then was started on Ozempic, semaglutide, which is a GLP-1 receptor agonist that I'm sure we're all very familiar with. So the first visits were not in person. They were telemedic visits with a specialist. And so weight, A1C, and BMP were not adequately monitored. And the GLP-1, the semaglutide, was increased incrementally based on the family's report of improving blood sugar. The clinic, there was a clinic visit where this medication was increased to 1 milligram But the patient was not weighed because she couldn't stand. And to give you reference, the maximum dose of Ozempic is 2 milligrams a day. So unfortunately, 6 months later, this patient presented to the ED with delirium, nausea, decreased appetite and oral intake. She had lost 28 pounds. So her BMI now or then was 24, down from 30. And she was suffering from hypernatremia, kidney injury, secondary to dehydration. So this case does end well. The medication was stopped, the GLP-1 was stopped, and she was rehydrated, and she slowly, gradually came out of her delirium, and her kidney injury and hypernatremia also corrected. So some of the things that I wanted to mention, just kind of as a generality, is when we're telemed. So there are limitations to telemedicine. It's important to note or to remind ourselves actually that this service is often established outside of ordinary protocols, and especially for medications that require objective data for adjustment or monitoring of side effects. We have to be extra diligent about, finding ways to get that information, because less than ideal information or misinformation can be perpetuated. And this is especially important, of course, when we're dealing with patients with dementia. In the context of age-friendly health systems, which we are one of them, we are, as you know, always being diligent to pay attention to our 4 M's, so mobility, medication, mentation, and what matters most. So one nice thing about telemedicine, as far as what matters most, is often patients do like to be in their own home, feeling comfortable and safe. But we do need to be extra vigilant in our observation and active listening in order to assess those other components of this 4M structure. The other thing I wanted to this is a general caveat, is we really want to make sure that we are not starting long-term medications, which this class of medication is considered, for short-term indications. Another example of that would be, for instance, if you had a patient with acute pain and you changed the the short-acting opioids to a fentanyl patch, that wouldn't be appropriate. All right, so we have a number of these on the market. Exenatide was actually the first one that came on the market in 2005. It's the only one that is actually in generic formulation. It's once a day for type 2 diabetes. Trulicity, dulaglutide, as a weekly type 2 indicated medication. And then, of course, we're very familiar with the semaglutides, so Ozempic, indicated for type 2 diabetes. This is a once weekly sub-Q into the skin injection. Wegovy is the weight management, once a week formulation. And then there is also a daily tablet, Rybelsus, that patients can take. And then liraglutide is the other GLP-1 agonist on that is available, and this is once daily. So Victoza is the brand name for the type 2 version, and Saxenda is the one for weight management, which, by the way, came on the market about 2014. So Wegovy and Wegovy came on the market much later, but we've actually had weight loss indicated as GLP-1 agonists for a while. And then I just want to show you the pictures of what they look like, just because I think it's helpful when you're kind of counseling patients. So most of them come as a multi-dose pen that you attach a needle to, and then you have to dial up. And I think what's important to maybe notice is that they look very similar to insulin, long-acting insulin pens. The Trulicity is a one-use pen. So once it's used, it is discarded. And then again, I don't want to get too much into the weeds about how these work, but I think it's important when we're thinking about side effects and the elderly, kind of where the receptors are. So there's a lot of GLP-1 receptors in our body, specifically for diabetes. The way it works, helps to work, is that it reduces gastric emptying. So patients tend to feel full longer. It works in the brain to help reduce appetite. And then specifically for diabetes, it does increase insulin secretion, decrease glucagon secretion, and increases beta cell proliferation. And then you can see that it has other effects. So for instance, in the kidney, potentially increasing sodium excretion, which then can reduce blood volume and then blood pressure. And then in the heart, there's some cardioprotective effects via its mechanism to reduce inflammation, and also for its anti-arthrogenic. There is then the twin incretins, which are basically a dual GLP-1 inhibitor plus GIP gastric inhibitor polypeptide. Tirzepatide is the brand chemical for this, and you might be also very well aware of these medicines. The type 2 diabetes formulation is known as Mounjaro, and the weight management formulation is Zepbound. And they also come as a daily injection, or excuse me, a weekly sub-Q injection, one-time pen that you throw away afterwards. So these medications are everywhere. We're all very aware of them. So in the news, various magazines, including financial magazines, general magazines, and then there's a whole spin-off industry dealing with weight loss and making sure people have the proper supplements to go with that. And then there's the Ozempic face from great quick weight loss, and et cetera, et cetera. So they are everywhere, obviously. Why they have become so popular is for a number of reasons. Studies have shown, so we've all read those probably medical studies, showing that they have some very formidable other potential health benefits in the cardiovascular and renal realms. And they have been now proposed for other disease states, such as addiction treatment, et cetera. There is direct-to-consumer advertising and media that people are being blitzed with, social media, testimonials. And also, because they became so popular, the FDA did make a special, granted special temporary permission for companies that were not drug companies necessarily to be able to make these formulations. So because of these GLP-1, the GLP-1 shortage, which the drug companies now have kind of addressed and bumped up their supplies. So obviously, this isn't so much a problem or a warning now, but of course, you always want to be getting your medications from FDA-approved companies and sites. So this wasn't obviously ideal. So some of the benefits of GLP-1 agonists. So we've already mentioned weight loss. It is important to note that each type of GLP-1 receptor agonist does have different efficacy as far as weight loss and cardiorenal benefits are concerned. They all are helpful for reducing A1C. And so the main A1, or kind of the median A1C that's seen with these is about 1.2, but it is related to dose and also to the agent. So the range is between 0.8 to 2, with the caveat that tirzepatide, that combo product, has been shown to give a mean A1C reduction a little higher than that, like 2 to 2.5. Trulicity, Ozempic, and Victoza also are FDA approved for cardiovascular benefit, as well as having evidence for renal benefit and overall mortality benefit. And so that's why certain guidelines, for instance, the American Diabetic Association has moved these agents to first line, recommending them as first line agents, depending on the patient scenario. Concerns for GLP-1s in our elderly. So as illustrated in this patient, dehydration is a potential problem. So we want to, and with obviously then potential for increased risk of falls. Orthostatic hypotension is something we need to be monitoring. And there are some kidney and liver function concerns as well. So these are all things that we want to be keeping our eye on. All of these agents also cause some GI upset, and so they are all dosed where at a very low dose and then incrementally increased so that patients can gain some tolerance to them. And then especially in our elderly where we're worried already often about muscle and bone, we want to, clock in that they potentially can exacerbate these problems. So muscle loss and bone loss secondary to weight loss is a possibility. And there's such a focus on this class of drugs as far as weight loss. And so I wanted to just throw this slide up to remind us that there are potentially some protective effects of adiposity in the elderly, kind of known as the obesity paradox, because in midlife, we know that obesity does contribute to an increase in potentially progression of Alzheimer's disease and also cardiovascular disease. But what has been found, at least in some epidemiology studies, is that higher BMIs are associated with a reduced risk of dementia, Alzheimer's disease progression, and increased cognition. So of course, we need to, look further to see about causality, but it's important to kind of keep track of that. And then also there was a study with patients greater than 60 years old and who were modestly overweight. And those patients were associated with a lower risk of comorbidities compared to those patients that were considered, in a lower BMI, normal range. So in general, just kind of as a caveat, BMIs in the elderly between 25 and 30 have shown to have some protective effect against mortality. Now, of course, there is the caveat that protective effects do tend to disappear, when you're hitting BMIs of greater than 30. And certain populations are a little more sensitive to obesity-related complications, the Asian population being one of them. And so actually the World Health Organization has lowered their BMI thresholds in response to those findings. So the other thing to just keep track about is if you are using a GLP-1 for diabetes or for the cardiorenal indications, you want to ask yourself, is weight loss desired? Because when we are, as I mentioned before, we start low with these medicines for GI tolerance, but we are titrating up in order to get to that kind of glycemic control that you would like. However, weight loss reduction does start lower than that. So even as you're titrating up, you are kind of instigating this potential for weight loss. And as you know, weight loss can potentially be more difficult to regain in the elderly. So I did try to find a little, kind of concrete information about this based on studies. And, semaglutide, Ozempic, when that was looked at, after 1 year, this is either good or bad, depending on the lens you want to use. Only 2/3 of that patient's weight they gained back their weight. So even after a year, they were still kind of a third of their initial weight down. Liraglutide, looking at that at a 4-month time frame, showed that patients had only regained about 14% of their original weight. So again, good and bad, but oftentimes with elderly, that isn't necessarily a good thing. So potential weight loss. So when we're looking at our GLP-1s that have indication for weight loss, these are kind of what the percentage total weight loss one might expect over a year. So Saxenda, which is liraglutide, has, of the three, kind of the least impact on total weight loss at a 6 to 9% total weight loss percentage. Wegovy, semaglutide, Ozempic is its counterpart, 15 to 17% potential weight loss over a year. Zepbound, tirzepatide, is the most potent at 20 to 25% potential weight loss after 1 year. And these are the milligram strengths so these are at the maximum milligram strengths of these medications, by the way, that are listed there. As far as using GLP-1s for diabetes and kind of wanting to clock in on how much weight am I potentially going to see with a patient, I couldn't find percentages. So I think the caveat is that, first of all, the dosing for GLP-1s that are indicated for diabetes are generally slightly lower than those that are indicated for weight loss. So I think just a generality is that we can expect slightly less weight loss than the above percentages, with the caveat that Trulicity probably is the least potent of the GLP-1 diabetic GLPs, although I would say it's not much less than the others. Okay, so some recommendations. We talked about nausea and vomiting, and that there's kind of a built-in mechanism for helping truncate that by the dose needing to be titrated, and it's generally titrated, by the way, monthly. But also eating smaller meals, low-fat diet might help with that. Weight loss is usual, and so we want to make sure patients are, consuming good sources of food, good protein, vitamins, etc. You want to be clocking in and encouraging patients to maintain adequate hydration, which we do in general, especially in the summer with our elderly. But you want to be especially cautious or reinforcing when patients are on diuretics. As far as hypoglycemia goes, the mechanism of action of these particular agents don't put people really at risk of that. However, if they are on other medicines like insulin or sulfonylureas, which already put people at risk for hypoglycemia, you might want to be kind of preemptively adjusting those dosage depending on your patient. And then as far as pre-op, according to the 2023 American Society of Anesthesiology's consensus guideline, they recommend holding your daily GLP-1 the day of procedure. And if you have a patient on a GLP-1 that is a weekly dosing schedule, then hold it the week before. The caveat, though, is actually the UW policy states just holding any of them just the day before or the day of. And I think that's probably because the patients are already NPO anyway. So I ran through that kind of quickly. This case that Dr. Slack's going to be presenting is very interesting and very complicated. So we'll hopefully have a good amount of time for that. But some things that I just wanted to restate. Firstly, is that, there's multiple mechanisms of action of these medications because they have lots of, again, receptors in different organs. But they are good agents, obviously, for improving glycemic control and for weight loss benefit. They do have some solid evidence for both CVD and renal benefits for Trulicity, Ozempic, and Victoza. And we do, again, want to be carefully pre-screening and continuing to monitor these patients, getting physical weights when we're prescribing them. And if, depending on whether you want this, I would say probably in our elderly, we don't want a supercharged GLP-1 added. But if that is what you want, tirzepatide has shown the greatest weight reduction in clinical trials to date. Now, I didn't talk about this, but I did want to touch on this, that there are barriers to starting these medicines and maintaining their use because they are so expensive, that there are some insurance, we need to consider whether or not they're going to be covered. Medicare in general, for the indication of diabetes, will often cover them for that indication, but a prior authorization is needed. And we also want to just make sure patients are okay with self-injections, sub-Q injections, because some are not. And then we should expect more of them, more of them on the market and more talk about them, because there's been a lot of research, ongoing research on potentially expanding their roles to other disease states. And with that, I will conclude. Here's the evaluation survey that I would appreciate you filling out. And I hope we have some time for questions. Otherwise, I'm happy to individually answer things afterwards or by email or anything like that.
We definitely have time for a few questions. Thanks so much for that presentation, Carol. It's good to think about considerations for older adults with these meds, since we're all getting used to using them, and we get asked about them quite a bit. And there's a lot of direct consumer marketing. So a lot of people are asking me about these meds in clinic, and I'm sure many of you are having a lot of discussions about these meds and using some of them in your clinical practice. What questions do you have for Carol? Ruru.
Thanks for that talk, Carol. I was just wondering that I know that we often start GLP-1s because we want that cardiovascular and renal benefit as well for our patients. It's always nice to get a twofer or a threefer for whatever we prescribe. And I guess I was just trying to understand if you have a good sense of the time to benefit with that, knowing that so many of the studies kind of use an age cutoff of 75 or 80. And so sometimes I'm not sure that our patients are truly seeing a benefit and more of the side effects. So I was just curious if you have some familiarity with that or some guidance there.
Yeah, so I know I don't have a sense of time to benefit necessarily with as far as cardiovascular goes. A while back, there was this mandation that you couldn't introduce a medication for diabetes reduction, or excuse me, glucose reduction alone, that you had to have some other additional proven benefit. So I don't really have a time to benefit for that necessarily, no. And you're right, for when they're talking about where this place in therapy is especially good is for patients that have ASCVD risks, solid risks. And so, that kind of, we don't really characterize patients that way as they get older. So I would look at it as more of just using it for diabetes with that kind of just potential benefit, but not mandated necessarily for that reason.
I do worry a bunch about the muscle loss that you see with these medications in folks that are losing weight with them. You can have quite a bit of sarcopenia, and that is obviously even more important for someone who might already be at risk for falls or who's already experiencing muscle loss. I have been very proactive in talking to patients about that before starting these meds and while they're on them, to be very proactive about an exercise program to maintain strength while they're on these medications, to try to offset that muscle loss, especially the functional muscle loss.
And that's a good point too, because in fact, one of your patients, I know you know who I mean when I mention this. Some people just even as far as consuming food, just their appetite really falls off, and they have to almost remind themselves to eat. So talking about it slightly differently there, but it is actually a really real thing as far as appetite suppression goes.
Thanks, Carol. And it looks like we found an article that showed the time to benefit for cardiovascular benefits of GLP-1s is about 4 years. So I was thinking about when things will help our patients. So thanks for pulling that up, Ruru. Any other questions for Carol? Well, thanks so much for teaching us. I know this will be evolving, but it's really good to think through things carefully. So